Hey Nick, can you hear me?
Yeah, I can hear you, but I'm gonna go out and come back in to the email from my computer.
Okay. Okay. All right. So just pause it until we get everything situated. Let's see. Nick, when you were on there, you were able to see me, right? Before I brought you on?
Yeah, I can see you. I just took myself off.
When you were in the attendees though, right?
Yes.
Okay. Just want to make sure that we don't have to do anything to bring them on. Okay. It is 12 o'clock. All right, ladies, are we ready? Great, great. Good afternoon, everyone. Thank you for joining us at the One Brooklyn Health Black Health Matters Getting Access. Today's conversation is an important one. Access to healthcare is more than appointments, buildings, or insurance cards. For many Black and Brown communities, access is shaped by trust, proximity, affordability, lived experience, and whether people feel seen and supported when they enter the healthcare system. Across Brooklyn and beyond, we continue to see disparities in health outcomes that did not happen overnight. They are results of long-standing systematic changes, resource gaps, and barriers that too often prevent communities from getting the care they need when they need it. As a safety net hospital system, One Brooklyn Health serves communities with deep needs and incredible resilience. OBH stands at the intersection of care, delivery, advocacy, and community partnerships, working every day to close gaps in access while navigating the realities facing health systems today. Today, we are honored to hear from OBH leadership who will share their perspectives on what access looks like at both the system and ambulatory care levels. These challenges safety net institutions face, and most importantly, what is being done to move health equity forward. This is not just a discussion, excuse me, it's a shared commitment to transparency, collaboration, and action. And we encourage everyone here listening to reflect and think about how each of us plays a role in improving health outcomes in our community. So let's get this conversation started. Before I start, let me introduce our panelists, which many of you who are on here knows. Our first panelist is our CEO for One Brooklyn Health, Dr. Sandra Scott. The
Hi, thank
second panelist is our Medical and Ambulatory Care Chair, Dr. Nanette Thomas. And our third panelist is our Ambulatory Care VP, Miss Marisol Walker. Thank you so
you.
much, ladies, for joining us. This is a very important conversation of what we have that's just hitting our communities left and right, and we are in the center of it. So we're going to get started, my first question is going to be for Dr. Thomas. Dr. Thomas, when we talk about health care access in Black and Brown communities, how do you define true access beyond having hospitals and clinics? And how does leadership decisions influence whether people actually receive care?
Well, thank you again for inviting me to come on today. I'm thrilled. I think this is an extremely important issue to discuss. And I think it's important for everyone to understand what One Brooklyn Health is doing to improve access for our community. As you stated earlier, access is not just making appointments, it's making sure that the patients have the ability to access care every step of the way. So some of the things that we're looking at, as you've mentioned, are making sure that we have appointments available and ready. There are some specialties that are always difficult to obtain, but we're always making an effort to increase the numbers of staff that we can get in those particular areas so that appointments will not be spread out and delayed for a long period of time. But some of the things that are a little bit more sensitive and more difficult to address are affordability and insurance coverage. Um, with the passing of the Big Beautiful Care Act, it's become a lot more difficult for individuals to access health care. This bill was actually created so that we could have more money moving toward defense issues, border enforcement, and building up the ICE enforcement also. But this has unfortunately led to a lot of cuts around social concerns such as food assistance, healthcare, and education. So One Brooklyn Health understands that our community may have less access to health care, that they may be losing insurance, that they may have to do a lot more in terms of filling out paperwork in order to access the care. We know also that the government has had less funding to safety net hospitals. So there is less of a funding for us to just manage the care of the patients and puts the hospital at greater risk in terms of financial windfall. And then for those individuals who've had Obamacare, they're already being instituted with higher costs for their care. So unfortunately, there are some individuals who may lose their ability to have health insurance. And it's estimated that across the country, there are about 7 to 16 million who will be affected. So this is one of the things that we have to address. We also know that in our communities, especially where we are in central Brooklyn, we really only have access to buses, public buses. We don't have a real train network, so it is difficult to get around. So for our ambulatory care sites, we try and put in as much at those sites so that our clients, our patients do not have to come to the hospital for care. So increasing the number of specialties that we have at the sites. We've also had mobile mammograms, mobile mammogram buses that have occurred at each of the sites so that our patients do not have to travel as far. And one of the most important things that we're dealing with is the digital access divide. We know that a lot of our younger patients are a lot more facile in using their phones, receiving texts. They do a lot of work on their phone that older individuals, more seasoned individuals, have a lot more difficulty in doing. So what One Brooklyn Health is doing is that we are creating a call access, which will allow patients to be able to call in 24/7. It will act as a hub that will allow for managing patient care, for making appointments, for making referrals. So for those who aren't comfortable with making all of that information online, or through their phone, they'll be able to have full phone access to all of our services. And then there are some who have difficulty leaving their homes for various reasons. Either they are debilitated or they have anxieties. Or they just don't have the funding to get out to have the transportation. So one of the things again that we're looking at are improving home care services so that we can go into the home, provide services, evaluate the patient, make assessments, and still maintain and provide good care for our patients. So these are some of the things that we're doing to ensure that we have good access for our patients.
And you're making it accessibility as well as convenient, because a lot of times, a lot of our patients are seniors. A lot of the patients, it's
Right.
hard to get, especially with the snow and things like that. So we are making things accessible for our patients and the community. We just need to make sure it gets out to them. So thank you so much, Dr. Thomas. Our next question is for Marisol. Why do disparities in access and health outcomes continue to exist in Black and Brown communities? And what systematic barriers must be addressed to create lasting change?
Great question, Sharon. So health disparities persist because they're not accidental. They're things that have been going on long-standing in communities that are structural and systemic barriers that shape where people live, work, education, and how they receive care. First, there's structural racism that's historical, where and how we treat our patients, their housing, education, employment, healthcare policies. So with that, there are economic barriers, there's access barriers, and there's social determinants of health. There's the mistrust of the healthcare system that have influenced how patients access the care around them, and how they just really have a mistrust of the healthcare system. So with that, with structural racism, they have fewer clinics, clinic hours, it's high rates of chronic disease. There's, and these things are always compounded over the history of generations of family members. Then many Black and Brown communities, they just don't believe in the primary care providers. There's limited access to primary care specialists, even behavioral health services. And with limited hours, long wait times, language barriers, and poor, as Dr. Thomas said, poor access to transportation have contributed to making this a continuous problem and difficult accessing care. With the economic and social determinants of health, such as food insecurity, unstable housing, unsafe communities, poor living conditions, and just limited job opportunities, this has alone also contributed to the health system that often treats illnesses and addressing these issues. As far as the mistrust of the healthcare system, it's rooted in historical and ongoing experiences of biases and discriminations that will discourage the engagement with care. We've noticed this even when it was with the COVID vaccine, to give you a little example, a recent example. It was that many people just didn't trust that this was a good vaccine, that it was going to save lives and so forth, because they would just go back to historically, they're going to test this out on us. But that's a good example of the mistrust that people had with our just any healthcare system, just not ours. But to create lasting change, we have to address these barriers by investing in community-based primary care and preventive care. So especially with our ambulatory services, we're looking at meeting the patients where they're at. We may need expanded hours, different services. We need to look at what services they need, which we are currently doing, and really reshaping ambulatory care. We're expanding cultural competency and language, making sure that we address the language barriers that we have with patients, making sure that we can really make them feel comfortable to come in and know that there is someone that can speak their language, or they have access to interpretive services immediately to help them navigate our health system. Then integrating social services with our healthcare delivery, helping them with food insecurities, trying to help with transportation issues, and addressing some of the immediate concerns that they're having. Additionally, in ambulatory, we are using data to help us identify these disparities and really help close the gaps and make these decisions for our system. This lasting change is beyond just, structural reform and investing in our community, but it's really a partnership with the community to show them that we are here, and we are to be trusted in treating them fairly and giving them the access to the care that they need, and being a responsible health system and partner with the community.
Thank you so much, Marisol, with that, because it's very important for our partnerships. Like, we can't do it by ourselves. We need the community, we need our partnerships, we need the faith-based organizations to help push the narrative. And then when there is a problem, that's where people lose the trust. But the thing is that people need to reach out to us and tell us when there is a problem. The one thing that I do not like is when I go on social media and I see somebody post something about whatever, instead of, you have the tools, build a relationship with us, build the trust, and that's where we'll be able to bridge that gap, where people will now start trusting us, OBH, for our services. So thank you so much for that. The next question is for Dr. Scott. As a safety net health system, what are the most pressing challenges OBH faces today, and how do those challenges directly impact access to care and community trust?
Oh, well, thank you for having me, Sharon, and thank you for this forum. Well, I think the previous two panelists really highlighted some of the biggest challenges that are faced, not just by One Brooklyn Health, but all safety net institutions, and not necessarily in order of importance, but I think the financial challenges that both the health system faces as well as our communities face really are a major barrier to access, right? So, like Dr. Thomas mentioned earlier, because of the changes and the regulations around Medicaid eligibility, we know that many of our community members will lose access to health insurance, right? Or their premiums will go up and impact their ability to purchase their medications, impact their abilities to do the preventive care. I think that Marisol mentioned the importance of primary care and importance of taking care of yourself before you require hospital services. So those preventive checkups, getting your mammograms, getting your colonoscopies, getting your yearly checkup, just getting your baseline labs once a year to make sure that your iron is appropriate, you're not anemic. And so if you catch those conditions early, the total cost of care goes down, not just for the individual, but also for the health system. If we wait until we're requiring an emergency department visit and we're deathly ill, not only are the outcomes often worse, but also the cost of care goes up. And so one of the challenges is to make sure that our communities have the health literacy they need so that they can understand the importance of a checkup, the importance of taking that time to sit with your provider and talk about your health concerns, your sleep, your diet, right? Your stress. How are you managing stress? We know that mental health challenges have increased dramatically since COVID-19, with anxiety and depression kind of leading in terms of conditions that people are suffering with. If you're suffering with anxiety and depression, it makes it much more difficult for you to do the regular things in your life, let alone getting good access to care. So what we need to do as a health system is to lean into those challenges that we know the community is facing. And our whole goal is to look at population health management, right? So that we keep the community healthy in the community, and there's less need for hospital services because people are healthier in the community. And overall, that's a better outcome for community members, and it's also a better outcome for health systems. So we're going to lean into education. We're going to lean into supporting people through those barriers that prevent them from accessing care, like Marisol named a few, in terms of transportation, food insecurity, housing insecurity, et cetera. And, we want to work in partnership with our community-based organizations to address those issues that prevent people from focusing on wellness instead of sickness. Thank you.
I agree, Dr. Scott. Thank you so much. And education is important, because if we don't know, we don't know, right? So if we are going out into the community, which we go out into the community, we do these educational health forums, OBH at your door. We come to senior centers, to faith-based institutions. We go to different agencies talking about the chronic illnesses that our communities face. So these are things that, you have to educate yourself and understand Why is it we are saying your ambulatory care services are very important? Because that's the root of your health care. And going right into that, the next question is for Marisol. Ambulatory care is often the front door to the health system. How is OBH strengthening ambulatory services to improve access to preventive care, chronic disease management, and continuing of care in underserved communities?
So at One Brooklyn Health, we see ambulatory care as the future, right? We are the most powerful lever to help the community improve its health. As Dr. Scott said, looking at community and population health, and as Dr. Thomas said, improving the access. We are working on different projects to make sure that we meet patients, like I said, where they're at, and creating better access for our patients. We're coming up with an access center to really be able to give patients better means to, we know we don't do some things well, like answer our phones. We are going to make sure that we have an access center that helps address these issues, making sure that you can go online, book an appointment, and help encouraging patients to use technology to help get them access to care, like through our MyChart. We are expanding and optimizing our ambulatory care sites, improving, like we said, scheduling, reducing the barriers that prevent them from being seen early or consistently, and making sure that we really improve continuity of care, because, patients will see a doctor, let's say a cardiologist today, and not come back to them for a year or 2 years. And we find that, and these are things that could be prevented if with consistent and continuity of care with these patients. We're also redesigning our care teams to better manage chronic conditions. We're going to have the use of care coordinators, navigators, and just taking a multidisciplinary approach to support our patients and manage the complex health needs on their own, and help them make sure that after they leave our ambulatory sites, that they're able to manage themselves at home and better help. Because if you treat one patient, one family member, and they really take an owning to their health, you notice that it will trickle down through the family. Equally as important as continuity, we're enforcing the strong primary care relationships and improving the transitions from primary care to specialty appointments. We're also trying to improve the transition between the inpatient to the outpatient setting. And if they're treated in outpatient, have better access to primary care, it will limit patients being admitted into the hospital, and have patients better, like I said, taking care of themselves by really partnering with everyone and really meeting the patient where they're at with their needs. We can improve the outcomes and improve the relationships between the community, and have them really look at us as a better trusted partner. And with hoping that all these things work as well as they do, that we know they will, that ambulatory will help prevent diseases and help people live longer, and just have a better owning of it, and better giving people better equity to their health.
Thank you so much, Marisol. You mentioned a couple of things that we really need to hone in on is, the access, our patient, but also what we do is we make it cohesive. So we do communicate with the families as well, because that plays a part with the management. If the whole ecosystem of not only just the hospital, primary care, but the family, if everybody's on the same page, we are able to have a healthier life. So I'm glad that we are able to do that. Yes, it is some challenges in getting that done, but we do have patients and we do have families that want to be part of the process for a healthy living. And one of the things that, Dr. Scott had briefly mentioned also was, we have to educate people to let them know the emergency room is not your primary care. So we have that issue a lot where people come into our emergency room, it's late in the game with their health, And now we're trying to get them a primary care person, but their health is just at such a disarray that it's going to cost more for not only them, but also for the hospital because the care. So we really want to let people know that the emergency room is not your primary care. It's not your regular doctor. It is emergency of what it indicates. It's an emergency setting. So we want to make sure, let people know, OBH, we have a series of primary care services and locations. And at the end of this, we're going to give you our website for those of you who do not know about OBH, but you will learn about our primary care services. Our next question
And
goes,
can I just add on that, because I think it's such a critical point, that especially for our communities of color, they often present with chronic diseases that are much more advanced, much more difficult to manage and control than if they had come in earlier. And as Marisol is mentioning, access to get into your primary care doc where you're going to have preventive treatment done on a regular and routine basis, the likelihood of picking up and then being able to treat, manage, and possibly cure some issues is much more favorable. And that's really something that we're trying to push out to the community, help them understand that regular and routine visits, getting to know your provider, having a relationship with that person is absolutely critical to their success and to their overall good health. So again, I second everything that's been said, that is really one of the most important things we can get across today during this seminar.
yeah,
Sharon, oh, sorry. Sharon,
no,
one thing I wanted to, when you mentioned that ER is not your primary care provider, one thing that we are really working on getting off the ground is really being able to navigate our patients from the emergency room and give them direct access to our outpatient services. So we realize that that is a problem for the community, and that is something that we're really looking at addressing. And to Dr. Thomas's point, really getting them into primary care and giving them that immediate access. We have same day access. So we know that if you come in and it is really bad in our providers, we're trying to make sure that we work with them so they can help transition these patients immediately to the outpatient setting so they can get an appointment with a primary care provider within 24, 48 hours. So these are programs that One Brooklyn Health acknowledges that is needed, and we are actively making sure that we're implementing those programs for the community.
Yeah, so I'm gonna double down on the topic as the emergency physician in the discussion. So Dr. Thomas, can you explain to the community the difference between an emergency department visit for your high blood pressure and a primary care visit for your high blood pressure? Right. So
Very,
what's the
very
difference in the experience for
yeah,
the patient?
very different. So typically, if you're coming to the emergency room with the diagnosis of high blood pressure, it means that you're having some kind of symptom, more than likely. So you may be having chest pain, you may be having tingling on some part of your extremities, you may be having some slurred speech, you may have swelling in your legs because your kidneys are involved. So once again, it's usually some organ that has been affected by long-term elevated blood pressure that is causing these symptoms. So once you've come in, you've already reached a point where your organs have been affected. The provider in the emergency room, depending on how high your blood pressure is, may have to give you medication by mouth or by vein. And depending on how severe your organs have been involved, you may have to be admitted to the hospital. Long-term management is going to be a lot more complicated and involved, usually a lot more medications that you're going to have to take. You may need additional treatment, maybe dialysis if your kidneys are failing, or cardiac procedures because your heart is already at risk. So a lot more complicated and difficult management for when you're presenting to the emergency room. However, if you're coming to your primary care doc and your doc notices that your blood pressure is elevated, Depending on the level of elevation, you will be started on medication at that time. And this will have been before you start having any organ damage. So you're treating it, you're managing it, you're usually on a lower dose than you might have been otherwise if you arrive to the ED late stage. And you'll just be, managed, routinely followed by your provider, depending on whether you can change some of your lifestyle habits by losing weight and decreasing your cholesterol. Your physician, your provider may help you actually get to a point where you can reduce or even remove your medication in total. So it's a really different look, ED versus primary care.
Right. And if you happen to show up in the emergency department because you need a medication refill, or you went to the dentist and your blood pressure was high at your dental appointment, the emergency department is not really the place where you're going to get the ongoing counseling and adjustment, right? So some blood pressure medicines have side effects, and the medication you may be put on, while it might be the appropriate first medication, it may not be the appropriate first medication for you. So I think that's another important distinction: the titrating and changing of your medication, and the counseling around the things that you can do to prevent progression of the disease. That happens in the primary care setting. So for someone who realizes the day before their prescription runs out that they need to, and they choose to go to the emergency department because, like Marisol mentioned, there are alternative ways to get your prescription refilled, for example, that doesn't require an emergency department visit. So I think that's important. As an ER provider, we would see patients routinely who came in not because they had end organ damage, but because they needed to quickly access care to get a prescription refill, and they didn't necessarily know how to navigate the system to do that without an emergency department visit. So I would encourage those listening to, before your prescription runs out, ideally the week before, that you explore how can either I have a just-in-time appointment, like Marisol discussed, if you feel like you need to have a conversation with your provider before that refill happens, or you facilitate getting the refill electronically and then schedule a follow-up appointment to just talk about the progression of how's this medication working for me. Because sometimes, it's the side effects may want you to change to a different medication, and that conversation is best had in the context of your primary care provider.
And that's really important, Dr. Scott, Dr. Thomas. Thank you so much. Yeah, a lot of times when I go out into the community, I hear someone say that they went to the emergency room because they needed to get their medication. They needed to, get something or refill, something to that extent. And my question to them is, do you have a primary care? Because that's medication management. The emergency room doctor is not going to do the management on your medication, especially if you have not been going on a regular basis. So thank you so much for shedding light on that. And with that said, Dr. Scott, you're up again. How does OBH measure progress when it comes to improving access and equity? And what does success look like for the communities we serve?
So the ultimate outcome is to improve life expectancy, because we know that the communities that we serve have a shorter life expectancy, even compared to communities just, a few miles away in Manhattan, right? So we look at population health management. So we were talking about high blood pressure, for example. So we measure our success by looking at how well are we managing the whole population that we serve. While your primary care provider is focused on you, we're also focused on the community, right? So we know that if the medication management and blood pressure control is good across a community, then we're doing our job collectively with the community. I think diabetes is another example where we can look at the population of patients living with diabetes and how well are they controlling their blood pressure as a population. So equity would mean that regardless of your zip code, that you have the same life expectancy and the same health outcomes. And that's the direction healthcare is going in general across the country, is really looking at population health management. so that we're moving communities towards a healthier and healthier lifestyle and healthier well-being.
You mentioned, Dr. Scott, that food is also one of the things that what we need to focus on. So food is medicine. So one of the things that I know that we are doing and other organizations are doing is having these food pantries. Having access to food is very important because if you don't have access to food, then you're not going to eat well. It leads to so many other disparities of your health. So putting things in place in terms of us partnering with healthy places that provide healthy foods, food pantries. The churches do a lot of this. We encourage people to please make sure that you look on the list. Like, I know our elected officials have a list of food pantries. I know different organizations, they do it. And we partner with food pantries as well, because at the end of the day, what we want to do is make sure that when you're coming in to see us, one of the issues is not food. One of the issues is that, we make sure that you do have something to eat and that there are resources. So again, thank you so much, Dr. Scott, for talking about that, and also for diabetes. Like, we have our Center of Excellence for Diabetes at our Pierre Toussaint location, which is located on Eastern Parkway in Utica. I mean, that is something where we know that is a chronic disease going through our community. So we are addressing these issues, and life expectancy, we want to make sure that it expands, but having access. So thank you again, Dr. Scott. And Dr. Thomas.
Well, just before we get to the next question, just piggybacking on to what you and Dr. Scott have mentioned, we are also looking to partner with God's Love We Deliver, which would actually be delivering food to our community. And again, Marisol talked about meeting our patients where they are. Some of our patients cannot get out of home, and we want to make sure that they continue to have good nutrition and are, being taken care of appropriately. And we also have the Food Justice Program, which allows for good, healthy food, vegetables, etc., which you may not be able to find easily in our communities. We have access here that we have that available to our staff and to our community on a weekly basis. So again, just trying to engage and ensure that we get the services to our patients that they tell us they need.
Absolutely. Absolutely, Dr. Thomas. And Dr. Thomas, the health equity is not the work of hospitals alone. What role do community members, faith leaders, elected officials, and local organizations play in improving access? And how can the community actively partner with OBH to close these gaps together?
Well, as Dr. Scott mentioned, we're very much moving toward population health management instead of just dealing with the patient one-on-one. We're looking to improve our community's health as a whole and understanding what health equity is, meaning that everyone has a fair and just opportunity to have a healthy life and a healthy lifestyle, and that we work toward removing the obstacles toward achieving that, such as poverty and discrimination and poor housing and poor food access. So these are the things that we're trying to accomplish. And we have a tremendous population health program. To start it off, on a regular and routine basis, we have what is called a community health needs assessment, where our staff work with a community health board to survey the community to find out what our community feels are their biggest health needs and concerns. They bring that information back, and then we evaluate the types of services that we have. And if we don't have services to adequately handle those concerns, then we will build programs around them, because we always need to stay in contact with the community to know what their needs are and make sure that we can support them. On a regular basis, when our patient comes in for their health care, we do what is called a social disease health evaluation. And we ask a series of questions around their housing, around their health, around their family. Do they have adequate food? What is their education? Do they have money? Do they have transportation? Do they have care for their children so that they can, manage in society? And based on those answers, we have access through some internet needs, but also as well as our social work network to help these patients when they are listing any particular concerns. We also have a very detailed chronic care management team. As Marisol had mentioned earlier, community healthcare workers, patient navigators, for patients who have chronic medical problems such as diabetes and hypertension, and may not be addressing them as carefully as they should. We have individuals who are reaching out regularly to ensure that they're picking up their prescriptions, that they're taking their medication. We supply them with monitors at home so that they can check their blood pressures or their blood sugars on their own and then report back. So we're doing a lot of work between the visit, not just when they're coming in to see their provider, but between visits also to help ensure that, they're being maintained and they know that they have a firm support structure in One Brooklyn Health. Some of the other things that we're doing is a violence prevention program. In the emergency room, when patients are coming in, we have a community healthcare worker who is identifying the patients who may not only be at risk, but who have come in because of violence. And we work with them, we support them, we support their families to try and understand what the issues may have been that led to this concern. And again, working with our community partners to try and support them and improve the situations as much as possible. So these are just a few. There are quite a large number of community projects going on now. And we have a lot of dedicated and really committed people who are working to help ensure that the health of our community improves.
Thank you so much, Dr. Thomas. As you were talking, I was thinking that, a lot of people, some reasons why people do not keep up with their primary care appointments or maybe with their specialty appointments. I'm pretty sure you've heard, both you, Marisol, and Dr. Scott, you've heard stories of why they didn't make their appointments, the dog ate their appointment list or whatever, or something to that extent. But, just going forward and just looking at how we are moving as, our lifetime expectancy and with population health. We've been talking about this for quite some time. It's now getting more and more prevalent to the community. But what do you think, and this is for anyone to answer, what do you think are some reasons why some of our patients don't keep up with their appointments, their regular appointments, to that extent? Because I look at it as a self-care, right? Healthcare is self-care. You love yourself. You want to make sure that everything is taken care of. You make sure you go to your appointments. But what do you think is some of the community or social determined type of excuses that we want to let people know that these are what we're hearing and this is not true? And I'm going to put this to Dr. Thomas first.
Well, again, some of the things that I mentioned when we were discussing access, and you can look at it at both extremes of age. When you're very young, you're healthy, you're moving around, you're making your moves in life. Health is not a priority for you. You're feeling good. You generally are not on medications. There's no reason to be concerned about it. When you go to the other extreme, depending on whether you have access to insurance, whether you are debilitated in any way and you cannot get to your appointments, or there's no good transportation to assist you in getting to your appointments. So these are some of the barriers that may lead to your getting to the appointments. And then there are mental health concerns. A lot of our individuals don't have the support to help get them to appointments. There are just a myriad of concerns and social woes that keep our patients from coming in. And, access to managing childcare is another important issue. It varies. And with an area like ours that we're working on, there's not much of support. There's not sufficient support either in the family or in the community to help these individuals. So unfortunately, their health care is, pushed aside because it's not critical to their survival at that time.
Makes sense. Dr. Scott?
So I think Dr. Thomas summed it up. I think it's both there are factors that are health system related. So, Marisol and Dr. Thomas talked about how we're expanding different ways for people to make appointments. I personally like to make my appointments online, and I don't want to pick up the phone and have a conversation because I make the appointments at the end of my busy work day, and I go on my phone and schedule my appointment, and that brings me joy. Whereas other people want to have a conversation and want to understand, how they should navigate their appointments. So they may have two appointments, and which one should go before the other. I think that there are clearly social barriers that we've discussed today that are real and impactful. And we're doing our part to try and help mitigate some of those challenges. But there are also excellent community partners that will provide navigation and community health workers. In addition, we have those resources, but there are also community-based organizations that have those services where someone can help you navigate the health system to make sure that you get your lab appointment and your radiology appointment before your specialty appointment, for example. And so I think that those are both patient-specific and health system-specific reasons why patients are struggle to prioritize and make their appointments. You do have a couple of questions in the chat. Okay, excellent.
Yep. I just wanted to make sure that we, did that because somebody texted me and asked me that, like, what are some of the reasons why people are not keeping up with their primary care visits, knowing that this can lead to other things. So we are going to go into questions. I forgot to put, and thank you so much, everybody who did put your questions in, but the household rules were please put your questions in the chat box so we will be able to answer them. So the first question is, sometimes we seek care and our concerns are disregarded, thus delaying diagnosis and treatment. I think that's really just a statement. That was from Lamine Isaac. The next question is from the same person. How is this factor being mitigated?
I would like to jump on that.
Okay.
Because this is something that is very, very near to my heart, near and dear. And the reason that I've worked only in communities that truly serve the underserved. We are a teaching hospital. We have a lot of residents, young people in training, residents and fellows in different specialties. And I take it very seriously to help educate cultural sensitivity, how to address our patients, how to be respectful, using terminology that is appropriate for the patients when they're coming in. And I have a great opportunity to help shape these young minds, not only as they're coming into the ambulatory care setting, but during educational sessions where they're, routinely being educated, not only on medicine, but general practice, how to handle a practice, how to work in a practice. So we want these young people coming in to be culturally sensitive and work with our community, understand a lot of their concerns, make sure that they're sensitive, and that they handle the issues that are brought to their attention. A lot of, we may not have as many people from the community as we would like in the hospital. That is something I know that we're always working to have occur. But for those who are joining us, we want to make sure that they understand the patients and where they're coming from and that they do address their concerns. So please, whoever brought this question in, I think it's absolutely critical, and we do spend a lot of attention and efforts to make it better.
And then I'd like to add too, we do have community health workers and navigators, and I think it's important that you escalate, right? So if you feel like your provider is not hearing your concerns, we have nurses in the practice, we have administrators who are in charge of the practice. So don't hesitate to escalate. Because sometimes there, to Dr. Thomas's point, there's a barrier in communication, and someone else may be able to help manage the misunderstanding between the patient and the provider. And I actually get, believe it or not, people know that I'm an emergency physician in my life, and I get texts and phone calls all the time for people all over the city. Regardless of their educational background, they're just not understanding their care plan, their medications. And so sometimes it's helpful to get another person involved in the conversation to make sure that there's clarity and understanding between the provider and the patient.
Absolutely. Same person, Ms. Isaac. Okay, she said, thank you for your responses. They're very helpful. The other question is mental health part of the care being provided by OBH in addition to primary care? Dr. Thomas, you want to start off, or Dr. Scott?
I think Marisol has a handle on all of our outpatient services.
We
Marisol, you
do,
want to take that one?
we do have an extensive mental health program, both here at Brookdale. We have it, and also at IMC campus as well. So all across One Brooklyn Health, we have an extensive access to mental health services as well as our primary care.
And also, just to let everyone know that next week, our next series for our Lunch and Learn is on mental health. So mental health matters. So we have a great lineup for that. So please make sure that same place, same time, same link for next week, Monday. You're quite welcome. You're quite welcome. Are there any other questions that we have before we close out?
I wanted to make sure that to just let everyone know that for multiple locations across our ambulatory network, we have extended hours. So we have our Bristol location is open till 9 p.m. 4 days a week. We have Pierre Toussaint. They are open till 7 p.m. 2 days a week, as well as our Bishop Walker location open till 7 p.m. I think it's about 3 days a week. So we have extended hours, and we decided to ensure that we have those hours so people can come after work. Because one of the complaints we hear that, well, they can't get off, they can't get there in time to be able to keep their appointment. So we have primary care open and available for patients during the week till the evening hours, as well as every Saturday at Bristol and Bishop Walker. We're open on the weekends. So we do have access. We've also, for women to make sure that they're taking care of themselves, we have our third Saturdays, we call it. So they're able to come in and get cervical cancer screenings on a Saturday at Bristol all day. And the reason why we've created these access is because people were saying they're having childcare issues, right? We have access to adult primary care, pediatric primary care every Saturday at our Bristol location. I believe it's every other Saturday at our Pierre Toussaint location, as well as our Bishop Walker location. They all have Saturday hours. So we have the access. And to Dr. Thomas' point, we would love to see more members of the community coming in and really taking advantage of the services that we have.
Marisol, you should also mention urgent care.
Yeah, so we also have our urgent care that is open also till 9 p.m. Monday through Saturday. So we have access. We would like everyone to look, come in, take care of yourselves. We want everyone to live long, healthy lives. Our urgent care also will help you transition into primary care and into specialty services. We have the access. We would just want everyone to know we are here for the community. We extended our hours to make sure that we meet your needs. We would love to see it utilized even more, but we are here. There's no reason to overwhelm our emergency department. Emergency departments across the city are overwhelmed right now, but we do have our urgent care. That we saw an influx of people coming in for the flu shot recently in our urgent care setting. So we are able to take care of a lot of your healthcare needs and help with the care gaps and then transition you right into our primary care services. So just let everyone know we are here for our patients. One Brooklyn Health is here to take care of the community.
Thank you so much, Marisol. It looks like this is a statement. If it's not a statement, just please, either just raise your hand if you want to ask the question. But it indicates we know that many members of our community are reluctant to share personal information for various reasons. Despite this, we are able to collect meaningful data on social determinants. Okay. Are we able, is that what you're asking, Mildred? Are we able to collect meaningful data on social determinants? And we can actually.
Yeah, Sharon,
Okay,
that
yeah.
was the question that she asked.
Yes. So she's asking if we are able to collect meaningful data on social determinants.
Yes, we have a work plan that has been developed for both ambulatory and inpatient occurrences to ensure that these questions are asked routinely. We have a whole plan about how it's addressed. Patients on an outpatient basis are given a form to complete. It's reviewed with their medical assistant, entered into Epic, and then reviewed by the provider. If any of the questions have been answered in the affirmative, then the patient can be referred for additional support and resources. So we do find this as, an excellent tool to open the conversation, to review the issues of concern that the patient is having, to help them address it, because we know that this is one of the barriers that will help prevent them from getting health care going forward. So we take it very seriously, and we've had, I think, great success, as we've been doing this work.
Okay, all right. We are coming to the close. Thank you so much for your questions. Thank you so much for joining us today. If we have any closeouts, Dr. Scott, do you have any closeouts?
Well, my closeout is a healthier you starts here. So we are here for you. And together it is our intention to continue to improve the health and wellness of the communities that we serve. And thank you for the forum, Sharon.
Thank you. Thank you. Dr. Thomas?
I agree. I'm very glad to be here. Always interested in getting the word out. I think a lot of great work is being done at One Brooklyn Health, and I'm happy to share.
And Marisol?
I couldn't have said it better. A healthier you does start here at One Brooklyn Health, and we are here for the community. We have multiple ambulatory care locations. Please come in, see us. We are here for you to keep you alive and making sure that everyone lives a healthier life.
Thank you so much, everyone. We appreciate you for joining us, taking your time during your lunchtime for our lunch series, our Black History lunch series with One Brooklyn Health. We did put the website, our onebrooklynhealth.org website, in the chat box. So for those of you who do not have access to us, please click on that link and you will get access to us, emails, and also our services and all of the things of what we're doing in the community. Once again, thank you so much. My name is Sharon Lead. I'm the Director for External Affairs and Government Relations for One Brooklyn Health, and we will see you next week at 12 o'clock for our second series of our Black History series, which will be on mental health. Thank you again, everyone.
Take care.